Good evening, everybody. Let me introduce myself and welcome to the webinar. Let me just so so thank you everybody for joining us. We're delighted to have so many of you here again for month upon month. So my name is Conchita Landefont, and I'm the Training and Engagement Officer for Southern England at Glaucoma UK. And I would like to introduce Areeb Moosavi, who's consultant ophthalmologist, glaucoma surgeon, and glaucoma lead at Milton Keynes University Hospital, NHS Foundation Trust. So we're going to have two short polls during the webinar. These are see the difference between these sessions are making. We're going to launch the first one now, and it will stay open for about a minute or two. Let me move that. Right. There won't be any presentation in this session, just purely Q&A, so we'll be able to focus that on the questions and answers. So please post any relevant questions here in the Q&A box. Don't forget to like the questions that others have asked, because we are getting more and more questions. Increasingly, it helps us to focus and identify which questions to answer. If you're watching on other platforms, please comment in the feed, and your questions will be fed into the webinar too. Please be aware that if you're using captions on Zoom, they may not be accurately translated, and don't forget to post questions that are on topic in the Q&A. So obviously Q&A is a bit of an open forum, but there's still stuff that kind of maybe not relevant to this session. So before we get going, we are enormously grateful to Areeb for generously giving his time to present in this webinar. We specifically invite speakers who are knowledgeable on the topic being presented. The information shared tonight is based on his own experience and knowledge and doesn't replace individual medical advice. Your circumstances are unique to you, so if you're thinking of making any lifestyle or medical changes as a result of this webinar, please speak to your eye specialist first. Glaucoma UK and Areeb are not responsible for any action you might take as a result of the information that you learn through this webinar. So I'm going to now hand over to Areeb, who's going to introduce himself a little bit more, and then we'll start with the questions.
Thank you. Can you hear me okay?
I can hear you perfectly.
I'm Areeb Moosavi. As you say, I'm a glaucoma specialist at Milton Keynes University Hospital. I've been doing this for about 15 years as a consultant now, and I trained at Moorfields and Birmingham Midland Eye Centre. I'm very keen on patient interaction and patient support. We run our own support group at Milton Keynes Hospital. Our next one's in June 26th, I think, and I'll send you a flyer to put on your website. So I'm very keen for these things. I think it's very important to engage with the patient at ground level rather than just attend conferences where everyone knows everything about glaucoma. Shall we get started with some questions?
Absolutely, yes. And please check on Glaucoma UK's website, because obviously all the dates for all the support groups will be on there, or just send me an email if you can't find them and I'll direct you in the right place. So don't forget to like the questions as they're coming in. And what we're going to do is we've had some ahead of time, so we're going to answer some of these first, and then we're going to go to the more popular ones on the Q&A. So when intraocular pressure is already well controlled, what additional measures can help slow down that progression?
So, interesting question. But when you say control between 9 and 11, that's one pressure measurement in the clinic. We know eye pressure fluctuates wildly throughout the day. It can be 10 millimeters of mercury fluctuation throughout the day and night. So just because it's normal in the clinic doesn't mean it's controlled. That's one thing to say. The other thing to say would be, if you're progressing, your visual field is getting worse, I would still consider operating. I've operated on patients with pressures of 10 because we want to get rid of that fluctuation that you get day and night so that we level it out. And we think that that is protective for further progression. Sometimes you just have to put your hands up and say, look, the glaucoma is progressing despite all our efforts and the pressure is 9. And we know it's 9 and they've had surgery and everything. There's only so much you can do. However, what does progression mean? If the glaucoma progression is so rapid that you're going to lose your vision in your lifetime, then that's worrying. But if glaucoma progression is very, very slow and you're not likely to lose your vision or useful vision in your lifetime, then that can be an acceptable progression, if you like. But it's difficult to answer that in one easy sentence. But it depends on the patient. there's a question there about lifestyle activities that should be moderated to avoid pressure spikes. Well, um, we all know about, I guess most of you know about yoga, and putting your head down below the heart level, downward dog position, is not good. That can raise your eye pressure between 6 and 11 millimeters of mercury. And anything that involves breath holding, so squats, deadlifts, unfortunately, high resistance wind instruments, if you're a musician, can also raise pressure. If you're a swimmer, wearing tight goggles that go inside the bones there and press on the eye itself, that's not good for eye pressure. So you want to wear large goggles that go around the bony area of your face so that they don't press on the eye. Vigorous eye rubbing, that's not good for your eye pressure. I've had patients where they always wear a really tight neck collar, really tight all the time, and they've got quite big necks, and that reduces the circulation around the eyes, and that can cause high pressure as well. So avoiding all these things. Caffeine, we know that caffeine can increase eye pressure, but I think you have to drink 5 or 6 cups of strong coffee a day. Now, if you're doing that, you've got other problems, I think. But I think in moderation, okay, but it can increase pressure. Alcohol, small amounts are said to reduce eye pressure, but other studies say they can increase pressure, and obviously large amounts of alcohol not good for you. You're going to destroy your optic nerve anyway. Sleep. So we know that sleeping propped up a little bit with a pillow or two is better for you, because your head is not all the way down, and it helps with the blood supply. Sleeping with your face down in a pillow is not a good idea in glaucoma. Diet, well, there's, to be honest, there's no strong evidence one way or the other about diet. Obviously, a healthy green vegetable diet is going to be good for you no matter what you've got. There is some evidence that omega oils, fish oils, are helpful for general eye health. Whether they're specifically for glaucoma is debatable. And the only other thing I've written down here is avoid smoking. Well, that's pretty obvious. Smoking can increase eye pressure, and it can affect the dryness of the surface of your eye, which doesn't help with drops. So that's what we started with, but you can tell me what other questions you want me to answer.
No, that's fine. And I just want to say that we're having trouble with our live stream. So well, obviously people that we're trying to live stream won't be able to see us, but I apologise for those of us that were expecting it to be on live stream. And that's we're looking into that at the moment. So the next question is, how effective are SLT and DSLT, which is direct selective laser trabeculoplasty, and in what situations may they be recommended?
So selective laser trabeculoplasty has always been a mystery as to how they work. I think the best description of how it works is that you deliver laser energy to the drainage angles of the eye, and that laser energy stimulates cells to eat up the debris clogging up that drainage angle. So it's like cleaning your drains, if you like, to allow more flow of fluid out of the eye, and so that controls the pressure. I think that's the best description I've ever been given to understand it. DSLT just means there's a machine now that delivers this selective laser trabeculoplasty all the way around the eye with a machine that you sit on, place your face in. Whereas traditionally it's done with a handheld lens and firing a laser. And they're effective. They're about 70% maybe success rate in modest reduction of pressure. But I wouldn't, and they're recommended first line use. So if I see a new patient who's never been on any drops, that's when you have to think about selective laser trabeculoplasty, because it works best on a virgin eye. That's an eye that's not had any drops. But I would say it's for lower end of the spectrum. I wouldn't be thinking about SLT for advanced glaucoma. It's a bit like tickling a grizzly bear. You need to do something more dramatic for the advanced glaucoma. And it also, there is some evidence that second treatment of it works better, and maybe even third treatment. So you can do it 2 or 3 times. If it doesn't work, and some people it just doesn't work at all, you give up on it and you move on to drops or whatever. But it's a good option for lower risk glaucoma, milder glaucoma, I would say.
Thank you.
There's some questions about Fixapost on here.
Yes, did you want to answer that one?
So I know that there has been a problem with Fixapost. I spoke to one of the reps, and she told me there was some flooding in one of the centers that makes the Fixapost over in France. So there was a delay, but she assures me it's all come back, but there may be a delay in the distribution getting to the pharmacy. So this happens from time to time. And someone's asked for an alternative. So preservative-free alternatives might be Ganfort, preservative-free, but that's very expensive. GPs won't be very happy. But Tapticom's another good alternative. That's a preservative-free drop. So that's something you might want to ask your clinician change it to.
Thank you. So we've got a couple of questions actually on YAG. There's actually, is YAG treatment safe for someone with glaucoma? And the other one is for glaucoma patients requiring a YAG. Is it
Capsulotomy.
yeah, after cataract surgery? What are the key risks?
Okay, so yeah, capsulotomy, for those of you, I mean, you've got a wide range of audience, so I better explain things. So after you've had cataract surgery, you can get a film grow over your artificial lens. It's a natural reaction sometimes to the lens being in the eye. It happens to about 20% of patients that have cataract surgery. So in order to treat that, we sit you on the slit lamp machine in the clinic, and we fire a laser to cut a hole in that cloudy bit. And you'll understand that I like simple analogies. So it's a bit like a net curtain's grown over your window, and we stand in your garden and fire a laser through your window to cut a hole in that net curtain so you can see out through your kitchen again. Now, it has its risks for everyone. There's a risk of inflammation or a pressure rise temporarily, but it's a generally very safe procedure. I know there is always quoted a retinal detachment risk, but it's very low. It's less than 1%. I mean, I've done thousands of these. I've never had a retinal detachment. So I'm really not sure how much of a risk that is. And I'm not sure whether there is any connection with glaucoma with that risk. I don't think there's any more risk because you've got glaucoma. Unless you have, maybe you've got glaucoma because you're short-sighted. If you're myopic, short-sighted, you have a very large eye and you're more prone to retinal detachment anyway. So maybe that's the link. But I think if you've got this film and they've offered you capsulotomy, I don't think you should worry about having glaucoma with it.
Thank you. So we've got here about MIGS. So how effective are minimally invasive glaucoma surgery overall, and when might an ophthalmologist recommend them?
So for a long time, there's been a gap between taking drops and then moving on to surgery, which is traditionally trabeculectomy surgery, has been around since the 60s. And there was nothing really in between. So this space has been taken up by MIGS, which is minimally invasive glaucoma surgery. These are little stents that we can inject even at the time of cataract surgery into the drainage angles, like little tubes, putting them into the drainage angle so it drains better. They're quite effective. They're probably around 75% reduce eye pressure by about 20% at the time of cataract surgery. But I would say these are for mild to moderate glaucoma. Again, advanced glaucoma, for me, trabeculectomy is still the gold standard. And if you're going to have a cataract, you've got mild to moderate glaucoma, it's a good opportunity to put in some of these stents at the same time. It only adds a few minutes to the end of the cataract surgery, and it could all be done under local anesthetic. So it's a good option for the lower risk group. I mean, you have to take into account patient factors. If I've got a 90-year-old patient who's got moderate glaucoma and she happens to be having a cataract operation, I'll offer some stents because it'll buy a little bit of time. You don't need to go through the big rigmarole of a trabeculectomy under general anesthetic. So you have to take patient factors into account. But they're pretty effective, but at the low end of glaucoma, again, mild to moderate glaucoma, I would say.
So you actually talk about advanced glaucoma. So we've actually got 5 likes on actually what do you
What
mean
is it?
by
I saw
advanced?
that. I
Yeah.
like that question. That's an interesting question. What is advanced glaucoma? Right. So for me, I would call someone advanced glaucoma if they have significant loss of visual field in both eyes. And if I feel that their glaucoma is causing them risk of vision loss in their lifetime. Now, advanced glaucoma might mean something different to a 30-year-old who's got moderate early losses, but they've got 60 years to live. But if you're 90 and you've got a lot of losses, yes, it could be advanced glaucoma, but it's less likely to be a worrying advanced glaucoma because it's stable, they've had treatment, and their vision is going to last them. So I think it's different things to different people, but to me, it means advanced losses in the visual field, and possibly trouble controlling the pressure with everything thrown at it. I'd call that advanced glaucoma, risk of blindness in the lifetime.
So the next question is, it's about kind of like PreserFlow versus trabeculectomy. So when choosing between that and trabeculectomy, what factors lead you guys to recommend one over the other?
So again, PreserFlow is better for I would say up to moderate glaucoma. Again, advanced glaucoma, I would probably go for a trabeculectomy. There's a lot of patient factors involved. So the PreserFlow is a little tube, if you like, that's inserted under the white of the eye and then just pokes a little tube into the front chamber of the eye, and it constantly drips fluid from the inside of the eye out under the white of the eye, and that's how it works by to lower the pressure. That sits inside your eye forever. So it's less invasive. It has less risk of having too low a pressure, because that's just as bad, in fact, probably worse than high pressure. So if your pressure falls too low, you could lose your vision. So trabeculectomy has a much higher chance of you having too low a pressure, which means going back to theatre and resuturing it. But PreserFlow, because it's a small tube, it's very unlikely to lower the pressure too low. But it has its own problems. You might need more interventions to keep it working. So we do sometimes need to do something like needling, where we put in, it sounds gruesome, but you put a little needle under the white of the eye and you just break the scar tissue to allow it to keep flowing. And that's much more prevalent in PreserFlow than it is in trabeculectomy. But it's quite successful. It's probably around 70% success rate in controlling eye pressure. And at 3 years, the mean pressure is reduced by about 45%. But the other thing that it does is it reduces your medication need. Your drops reduce by about 70% on PreserFlow. With trabeculectomy, you get a much bigger, better reduction in pressure, and you could be off drops altogether. And it has a very good success rate. I would say 80 to 90% success rate if you include patients that needed to go back on one drop or something like that. If you look at patients that were complete success with no drops, 60 to 80% success rate. But it can have more complications that need re-intervention and going back to theatre. But it's still the gold standard, even after all these years, 60 years. It's still the best at lowering pressure. So when you get to advanced glaucoma, or where you're really struggling, I would always go for a trab in the end.
So we've got a couple of kind of likes this one. So can you have a trab if you've had optic nerve damage?
Well, you do a trab because you've got optic nerve damage. That's why you're doing it. In glaucoma, the optic nerve damage has got so bad that it's all about the trajectory. If the trajectory of optic nerve damage is going to end up with loss of vision before the end of your days. Now, with my patients, I always calculate an age of 100, just in case you want to know what the end of your days are. If you live past 100, I'm not responsible for your vision. But if we aim for 100, that's pretty good for most people. So if your rate of deterioration is going to get you before then I'm thinking about trying to change that trajectory by doing an operation. And that's because of no damage. So actually, we're doing it because you have no damage. So the answer is yes, you can do it. You should do it if there's optic nerve damage.
I'm guessing, obviously, that we've got a question here about if it's unstable despite drops and surgery. So how quickly is it likely the disease will progress with more loss of vision? But I'm guessing it's difficult for everybody.
Yeah, it's very patient dependent. There are some patients I threw everything at them and they still lost vision. I mean, thankfully, rarely. I think the rate of blindness from glaucoma in this country is around about 4%. So I think the fear of it is worse than the actuality of it. And a lot of those patients have come with advanced glaucoma before I've even got to them. So, they've been missed or haven't sought treatment. So I think, I think it's rare to be able to have thrown everything at someone and still lose, but it does happen. I'm not going to say it's 100%. But I think it's overplayed in people's minds more than the reality in life.
So again, was kind of, I suppose, still on post maybe trab. So after a trab, is it normal for vision to be blurry or poorer after initially improving during the first several weeks? So what is it like kind of post-op, I'm guessing?
Okay. So because of all the suturing involved in trabeculectomy, you are going to get some change. Usually it's transient. You get a change in your vision. The cornea shape has been changed because you put stitches in it. So that all needs to heal. Everything needs to settle down. So it's not unusual to have a reduction in vision initially. That should generally improve. I've had patients who've had poor vision for a year and then they've gone back to where they were without me doing anything. So we have to wait for the eye to remodel from the surgery, from the trabeculectomy surgery. But there are many other reasons why the pressure might, for example, the fluctuation in pressure might mean that you get fluctuation in vision throughout the day because it's very volatile until it settles down. In doing the surgery, the pressure changes, so the lens position may change slightly. In other words, your glasses prescription might be slightly different now. That generally resolves, and I wouldn't recommend getting glasses for at least 3 to 6 months after the surgery until things are stabilized. But there might be a slight change in the glasses prescription. Trabeculectomy surgery affects the cataract, so it can progress faster than it would have done naturally. So that's another reason why vision might deteriorate. And if the pressure is rising, so the trabeculectomy is not working so well, then obviously the vision could change again. So there are many factors. And that's why after I do a trabeculectomy, I see people once a week for 4 weeks. That's the crucial stage, the 4 weeks. At the end of 4 weeks, if the pressure is okay, the vision is okay, then it's a month, 3 months. But every patient is different. And depending on what the cause is, we might be able to do some extra stuff for the vision. But fluctuation of vision is very common in trabeculectomy.
Thank you. So again, it should remain relatively stable throughout the day. So what about any significant diurnal variation? Does that suggest that it's failed, or is it just
So
how
in
it?
theory, the trabeculectomy is designed to stabilize your eye pressure. So you don't get as many fluctuations day and night. It should stabilize. But to get to that point, it might take a bit of time. So for the first few weeks, you might find fluctuation in pressure. It may not be draining as well. I put in 2 releasable stitches that I can take out in clinic. So if it's not draining enough, I'll take a stitch out and allow a bit more flow. So that adjustment period is at least the first 4 weeks. So you can get variation in vision and pressure during that time. But the ultimate goal is flat pressure, hopefully between 8 and 10 millimeters of mercury, and constant day and night. And then that's when everything stabilizes. But the first 4 weeks are very crucial.
So we've got a few, maybe, on supplements and glaucoma. So um, is magnesium supplement safe, beneficial, particularly before glaucoma surgery, such as Presoflow? Does it, so it's basically, what are your thoughts on magnesium supplements?
I think supplements in general, we're not sure about supplements. I think all studies that are done on it are confounded by the fact that that you might already be on treatment for glaucoma, you might have always have other things happening. And a lot of the studies are done on people diagnosed with glaucoma, and then you look back whether they had supplements, and it's a little bit, it's not concrete whether they have any benefit at all. There is some evidence to say that calcium and magnesium are protective in glaucoma, but I think the evidence is not greatly strong. But as with anything in life, anything in excess can be bad for you. So if you overdo it with calcium or magnesium, if you overdo any vitamin or supplements beyond the recommended dietary intake, you're liable to get problems. So if not glaucoma, you'll get other problems. So I wouldn't advocate that. I'd also suggest that, well, they're expensive for a start. They may upset other medications that you take. I would get it from a reputable supplier. You don't know what you're getting sometimes from the internet. Some people have suggested ginkgo is good, which is a supplement that increases blood flow, but then there's a risk of bleeding. So I wouldn't take that before surgery. For the specific question about magnesium before Presoflow, I don't understand the thinking there. I don't understand why it should help the success rate of the Presoflow. I mean, the supplement is the supplement, and whether you take it or not, I'm not sure it would make any difference to the success rate of the Presoflow. So take it or leave it, I would say, for that. There is some trials now on nicotinamide. I think it's B3, vitamin B3, but too much of that can cause liver problems as well. So anything in excess, probably not a good idea. And I don't think there's any definite supplement I would say definitely take that, makes a difference.
Thank you. Um, so obviously it's that flu time of year, so we're all going to get maybe a bit kind of under the weather. So if you've got like a cold or flu, um, which should people avoid and which are considered safe? It's that kind of quagmire of knowing, and I suppose in a way it could be even hay fever season as well. So which medications should, people need to take in terms of kind of relieving pressures of other pressures?
Yeah. Yeah, I mean, so it depends a little bit on what type of glaucoma you have. So if it's open angle glaucoma, which is 80% of glaucoma, then that's much less of a risk with any of these medications. Um, with closed angle or narrow angle glaucoma, there are a few risks, and you'll read it in the leaflets. The companies always cover themselves by saying, no, don't take it without your doctor knowing if you've got glaucoma. I mean, decongestants such as pseudoephedrine and phenylephrine, they constrict blood vessels. So they might increase eye pressure and they can dilate the pupil as well. So the pupil dilates. Now, if you've got narrow angles, dilation of the pupil might occlude some of the drainage, and so your pressure could go up as a result. But if you have been treated with laser iridotomies for narrow angles, then you're probably safe even with those. Um, in open angle, I don't think there's much of a risk in taking them. Antihistamines also dilate the pupil, so again, the same risks. I mean, paracetamol, brufen are safe. And if you wanted to try something that didn't involve those medications, if you're worried about those, then cough remedies and cough suppressants are all safe. And you could try the traditional remedies my mum taught me, gargling with salt water, saline nasal sprays, humidifiers, steam inhalations. They're all pretty safe if you wanted to try those. But I think on the whole, these drugs are safe unless you have angle closure, especially narrow angles that haven't been treated. So if you've ever been told that, probably avoid it. But open angle, usually it's okay. I get a lot of these queries from GPs and patients, and I just reply back saying, you've had this done, that's fine, or you don't have that type of glaucoma. So it's probably
So,
worth asking.
so if they've had narrow angles, but they've had like maybe laser surgery or something that
Uh,
so
My advice to that is if you've had a laser iridotomy, you're pretty safe. And we discharge those patients back to the optician. So I think even these drugs will not cause problems if you've had a patent iridotomy done.
thank you. Um, I've actually we've got so do you know any new or up and coming treatments are on the horizon? Um,
Um, so I don't think there's any, for years and years and years, all we've had is four groups of drops, four families of drops. There's only one new one come on the market recently called Rocklando that works in a slightly different way to the other four, but that has its own problems. That makes the eyes very, very red, injected. So the whites of the eyes become injected. So um, a lot of the future is around new drops or different types of drops that are kinder and work better to lower pressure. So there's work on a brimonidine drop, which is once a day prolonged release. There's drops of modified bimatopros that work with nitrous oxide that help drainage from other areas, not just the drainage angle. These are all in trial phase and development phase. Potassium channel modulators that reduce pressure by relaxing vessels and reducing the eye pressure, reducing the pressure outside the drainage angle, so you get more flow of pressure from the inside out, and so you get more flow. These kind of drops. They've also got transdermal eyelid drug delivery systems of travoprost. So you presumably you somehow place it on the skin or around the lid, and it transfuses the chemical in, stops you needing to use drops. There are sustained release options like implants that go inside the eye and slowly release drug. Implants that go into the little punctal hole here for drainage of tears. They can just put a plug in there and that releases drug slowly. There have been some lens implant developments. It's called spyglass, where you put uh, drug-eluting pads onto the lens implant that you put in at the cataract surgery stage, and they're said to last 3 years with the drug, so presumably get you off drops and things like that. Um, there are newer modifications of MIGS and aqueous shunts being developed. There's a laser called Elios laser, which is like a laser MIGS procedure. It doesn't involve an implant, but they are firing laser holes at the drainage angle to make little holes, so you have more drainage from the drainage angle. But I don't think, from what I've read, there's not a great deal of pressure lowering, maybe 4 or 5 millimeters of mercury, from what I've read. And then obviously you've got the other therapies coming out, gene therapy and things like that. But I think that that's a long way down the line at the moment. Stem cell therapy. I don't see those being available anytime soon. There's a lot of work to do there. There's hundreds of genes that can cause glaucoma, and you don't know which one you've got. So difficult, that kind of treatment.
I guess people are just obviously looking for maybe sort of like what's in hope, but I'm guessing it's because they have these things have to be approved anyway, don't they?
Yeah, they
By
have to have, yeah, I mean, I'm not trying to be negative here. We can still manage glaucoma with what we've got, and there are some interesting things coming out, but I don't think there's some fantastic cure coming out. I don't want to make people think that there's going to be a cure, but we are managing this disease so much better. I mean, even the generation before, they just were left to go blind because there wasn't much to give. If you compare from, even 50, 60, 70 years ago, it's huge
yeah.
difference in what we can do. So I don't mean to be negative at all.
So just one, I've got one more from earlier. Are you aware that obviously we talked about kind of difficulties with supply of drops, but are
Yeah,
you aware with the difficulties with some of the single dose units and how some of the um it's so hard to squeeze? And I know from the helpline that we do provide dispensing aids,
yeah.
but some of these newer ones don't even fit in with those aids as well. So I mean, I know there's not a lot maybe that you can do, but are you aware? What would you suggest to your patients if they're having
So
trouble
I
with?
think units should always have some. We have a glaucoma nurse who's specialist in glaucoma, and she has various drop aids that she gets from the reps. I think we just have to find what suits each patient. So for what's good for one patient won't be good for another. So there are many different drop aids going around. I saw one the other day, latanoprost drops, but it's been changed to this preservative-free latanoprost drop, which had a really interesting squeezing mechanism. I've never seen it before, and he showed it to me, and it looked much easier to use. So it's a question of shopping around. Maybe pharmacists will know what different types of injectable containers there are. It's very difficult to know. And you're talking about distribution. Some people are very dependent on preservative-free formulations that are single use, tear off a strip or a specialist dispenser. And if they go, there's from time to time, there's a problem with distribution with various different drops. There's nothing we can do about it. We hear about it from patients. They come and say, I can't get hold of this anymore. And then we find out later that because the reps are not going to advertise that their drops are not available, are they? They're not going to say, by the way, our drops are not available for about 6 months. They just allow it to happen while they're trying to fix the problem. So there's going to be times where we have to switch to something else. But the actual drop aid, that's a very difficult question to answer, and how we're going to, hopefully your unit, wherever you're being treated, will have somebody who knows about drop aids. The glaucoma unit should have someone who knows about drop aid. I'm going to get in big trouble with my colleagues now, but it's true. There should be someone who knows about these things, because there's so many on the market, and be able to help individual patients to get the drops in. Is it safe to swim without goggles? Without goggles? I I don't see a reason why. Obviously, if you've just had surgery, trabecular surgery or glaucoma surgery, I would refrain from swimming for probably weeks rather than months. But in I would say goggles are good. They're protective as long as they press on the bone around the eye and not on the eye itself. Um, Chlorinated water is not aseptic. It can still cause infections, even in chlorinated water. That may be a misconception. Just because it's got chlorine doesn't mean it's sterile. So certainly if you've just had surgery, I would avoid swimming altogether. I don't see a reason why you can't swim with goggles, without goggles. But if you go under the water, that's going to change a lot of the pressure variation across the cornea. So if it was up to me, I'd say wear goggles, but put them on the bony part of your eye. It doesn't matter how silly you look, as long as your eye is preserved. But it's an interesting question. How low does pressure need to drop after trabeculectomy for it to be a problem? My trial was 6 years ago, and pressure in that eye is 5 or 6. So that's an interesting question. How low is too low? So the definition of low pressure is below 7 millimeters of mercury. However, everybody's different, as you know. So some people have a thin cornea, which means the front windscreen of their eye is very thin, and that means we're underestimating their real pressure. So their true pressure could be much higher than what we're measuring. So someone with a pressure of 5 with a thin cornea may actually have a pressure of 10 in real life, but we can only measure 5. So that's something to take into account. The other thing is a lot of patients tolerate quite low pressures. I've got a couple of patients like that. I've got one patient who's got a pressure of 1 and has no problems whatsoever. Has perfect vision. There's no consequences of it. So the consequences would be that the inner lining of the eye, the retina, is folding in on itself, coming in. And when that happens, you can get shadows in your vision and things like that. And then we have to act. And also you get some rippling of the retina at the back of the eye. And so it affects your vision. You get distortion of vision and things like that. So we keep a close watch on them. If they're developing anything like that, we will have to go in and resuture it or refill the eye. There has been a colleague of mine I trained with at Moorfields who's been experimenting with injecting gel into the back of the eye to get the pressure to go up. And that's worked quite well. But I think that would, in my view, that will probably be limited to people with low visual potential in that eye. But because my first instinct would be go back in and revise the trabeculectomy and get it to work better again. But the value of the pressure is not the issue. The issue is whether it's causing you a problem. And generally something below sort of 3 is likely to cause problem in almost everyone. But if it's continuing to drop, that's a sign that we need to take you back to theatre and sort it out. But 5, 6 to me doesn't sound too worrying, as long as, especially if they've got thin corneas and also the back of the eye looks fine. I think that should be okay. Why is my pressure of 24 millimeters of mercury considered too high for me? Also, why am I diagnosed as a glaucoma suspect despite being given glaucoma drops for the last 5 years? Okay, so the definitions we would have is no glaucoma, glaucoma suspect, or glaucoma. Now, glaucoma suspect basically means we're on the fence. And the reason we're on the fence is the normal architecture of the optic nerve development is confusing. So you can't really see the normal anatomy of the optic nerve. It may be tilted, it may be the way it developed, you might be very short-sighted, and we can't tell from that exactly whether it is glaucoma or not. There are some field defects, and we're not sure whether the field defects are related to the development of the nerve or whether they are related to glaucoma getting worse. In general, for glaucoma, it has to be progressive deterioration. If it's progressing, then it's likely to be glaucoma. And then you can have a mixture of the two. You could have glaucoma on top of an unusual looking optic nerve. So sometimes we're on the fence. However, if the pressure is up or we're quite suspicious of it, sometimes the safer option is to start you on treatment. And that way we're likely to preserve your vision. And if we're wrong and you don't have glaucoma, I don't think you're going to lose a lot by having your pressure down. So of the two evils, I would probably err on the side of treatment if I was really concerned that something was progressing. So hopefully that it's not easy sometimes to diagnose glaucoma. And you're right, it's odd having glaucoma suspect against your name for 5 years. I'm always keen to switch it to something. So if it's been a few years, I would probably say, I think we can call this glaucoma now. So that's my general. I don't think you should be called glaucoma suspect for 20 years. I don't think that's right. But that's why on drug. And why is something about why is my pressure considered to be high at 24? So normal pressure for me, for for the normal population, what is normal, but non-glaucoma population is 10 to 24 millimeters of mercury. That's the range of normal. So somebody with a pressure of 24 could be completely normal. Another person with a pressure of 24 could have rip-roaring glaucoma. So it's all dependent on the patient. If you've got a normal optic nerve, normal visual fields, and only have a pressure of 24, I'm thinking about discharging you because you don't have glaucoma. You're at the upper end of what I consider normal. We also have to take into account the corneal thickness. A lot of people with a pressure slightly higher than normal have a thick cornea, and that's the reason why the pressure is measured high. And the opticians will be measuring with a puff of air and all that. That's even more affected by the thick cornea. So they often come to us, and when we measure the pressure, it's normal again. So it's not about the number, it's about the individual patient and whether that number is causing a problem or not. So I don't know your specific case. So 24 could be normal, 24 could be too high for a glaucoma patient. Depends on how bad the glaucoma is. I'm reading only from the bottom section, so I hope I'm not missing some. How can I know that my IOP, my pressure, is high between appointments? Interesting. For example, when I wake up at night with heavy eyes and a headache, could it be high eye pressure? So in my glaucoma patient support group, I show a slide of pressure differences between office times, between 9 and 5, and over a 24-hour period. So they did a study where they measured the pressure throughout the day and night. And the fluctuation in pressure outside of office hours is much higher than in office hours. So the answer is you don't know, but more than likely it is fluctuating higher and probably higher at night, because at night you're lying down, and we know that lying down flat can increase your eye pressure, and also your blood pressure falls. So these are two things that can affect your optic nerve, which is why we suggest sleeping with your head slightly propped up with a pillow or two rather than completely flat. How do you know what your pressure is? The answer is you don't. There are gadgets out there you can buy to measure your own pressure. They're in the thousands of pounds worth. We don't know. I don't personally know how accurate they are, and I don't know the significance except feeding fear, because if you're worried about it, you start measuring it every 5 minutes, you might just cause yourself to have more fear than necessary. And also, every time you measure it, the pressure can be different because it's just been measured. So the temptation would be to measure it every 5 minutes, wouldn't it? So, but they are thousands of pounds worth, and I don't know how accurate they are. So, but just know that it is likely to be a problem outside of office hours, and just to take these precautions by sleeping with your head sitting slightly up. If you're having a problem at night with your heavy eyes, it could be dry eyes, it could be other things that can cause those symptoms. So probably best to discuss it with your clinician when you next see them. Can you have a trabeculectomy later on after having Miniject? Is Miniject, I think that's one of the MIGs, isn't it? So the thing about trabeculectomy is you need a clean eye. You need an eye that's not had any surgery before. If there's scar tissue or something's been done before, you can't do a trabeculectomy, because the way the trabeculectomy works is you're creating an irrigation channel, and that fluid has to come out, and it has to have no scar tissue stopping it flowing all the way back to the drainage angles of your drainage vessels of your eye. Now, if you've got scar tissue there, first of all, you can't dissect properly, and secondly, even if you manage to do that, it will scar up again, it won't flow. So if you had any surgery before, any implants, then you would have to think of a different type of surgery. Probably, if you're advanced glaucoma, probably aqueous shunt surgery, which is a tube that's injected into the inside of the eye and goes back to a large plate that's sewn onto the white of the eye. It sounds gruesome, this at dinner time, doesn't it? But that's a good 2.5 hour operation, general anesthetic, probably in a tertiary unit, a teaching hospital. I wouldn't be doing it in a small unit like a district general hospital. That's if you've had surgery and scar tissue before. But that's why we tend to do trabeculectomy before we do any other invasive surgery on the white of the eye, because you can still do a tube after a trabeculectomy, but you can't do a trabeculectomy after a tube. So that may be one of the reasons why we decide on one rather than the other. I've been diagnosed with a thin retina. Will this restrict my options for glaucoma treatment? Thin retina. Do you mean thin cornea or thin retina? So thin retina just means the scans that you have, the OCT scans, have just found that the retinal lining is thinner than average. Now, that may be just the way you were made. If you are very short-sighted, for example, you can have thinner than average retina, and the machine is comparing you with whatever it thinks is normal, whatever's been fed to the machine as being normal. So you're comparing it with somebody else, but that may be normal for you. So the other reason you might have thin retina is damage. So if you've had a retinal detachment or you've got long-standing glaucoma, you could have thinning of the retina because the nerve fibers are dying off. So I don't think it restricts your options for glaucoma treatment. I would throw everything at you if you had advanced glaucoma, regardless of how thin your cornea, your retina is. If you meant cornea, then thin corneas means we are underestimating your eye pressure. So that's something you have to take into account. You probably did mean thin retina. As soon as the machine shows red, the optician will be referring you in because they're very risk averse. So we call it red disease. You know, they're treating the but no, it won't restrict options as far as I'm concerned for glaucoma treatment. Does a previous detached retina accelerate the sight loss from glaucoma, other things being equal? I would say probably yes, because you've had some damage already. Even though it's been repaired, it's probably still damaged. So then you've got the damage from glaucoma on top. So it's not going to help. It's probably going to be already slightly damaged before the glaucoma takes hold. But again, it doesn't mean you're going to lose your vision or go blind. Everything, you know, depending on the level or degree of glaucoma and your particular situation. But I don't think it's going to accelerate the sight loss. It just means you started at a bad point before glaucoma took over. Is it possible to have too low pressure? We've talked about this already, haven't we? Too low pressure may be okay for a patient, depends on the patient. The only reason you have low pressure, very low pressure or frighteningly low pressure, is either you've had surgery or you've had an injury, especially an injury that causes a penetrating injuries for the eye to be open to the world. So apart from that, or an eye that's so sick it's dying. If it's dying, it's not producing fluid, so the pressure can be very low. So unless you've had an injury, surgery, or over-treated for glaucoma, you don't usually have low pressure for just like that. I have normal tension glaucoma. Is there anything I can do to increase blood flow to, I can't read the rest of the question, to the optic nerve? Normal tension glaucoma, so that basically means, for those of you who haven't heard of it, is glaucoma with a normal pressure, meaning between 10 and 24. So you started with a pressure between 10 and 24 millimeters of mercury, and we've been struggling to get it low because we know that it's causing glaucoma. So the optic nerve gets damaged from the pressure in the eye, but it can also get damaged because the blood flow and supply of oxygen to the optic nerve from the other side is compromised. So if you have poor circulation, cardiovascular disease, Raynaud's disease, where you get really poor circulation, cold fingers and toes, you're likely, the small blood vessels supplying the optic nerve can get damaged. So, or not supply oxygen for the optic nerve. So it can look like glaucoma, you're getting progressive damage to the optic nerve, but the eye pressure is not the culprit. It's not the main reason why that's happening. So that's why you're getting glaucoma in the face of a normal pressure. Now, we still lower the pressure because there's nothing else we can do. We can't increase your blood flow. There's no drugs for low blood pressure. You've got loads for high blood pressure. You've got nothing for low blood pressure. And so the best thing we can do is lower the pressure in the eye, because that's the only thing we know scientifically works to slow down glaucoma. So even though the main problem is the blood supply to the optic nerve, we are taking the pressure off the nerve from within the eye to help it survive as long as possible. Occasionally, normal tension glaucoma is masking something else going on in your brain, which is causing the optic nerve to be slowly damaged. And sometimes we might ask for a scan of your head just to make sure we haven't missed something. But I don't want you to be worried about that. There are things to say that will tell us that it's unlikely to be a brain problem. But it's something that the clinician may think about doing. But I've forgotten the question now. Normal tension glaucoma. I forgot what the question was. I talked too much. I'm sorry. I've lost the question now. I hope that answered that. person's question. What is the success rate of trabeculectomy on a highly myopic eye where the tissues are much thinner, and or does the risk outweigh the benefit? Wow, these are proper questions, aren't they? These are not patient questions, really, are they? This is so very true. So a myopic eye, that's a very short-sighted eye, tend to be larger and they tend to have thinner tissue. So when you make your trapdoor for your trabeculectomy for the fluid to flow out, it's very thin. The white of the eye is very thin, and even though it looks good on the table, while it's healing, the tissues can stretch out and the thing could start hosing fluid. So we tend to try and keep, we still do trabeculectomies on myopia, but we tend to tie it much tighter because we know that as the eye heals, it's going to start draining even more. So we're much more cautious with myopic eyes. And sometimes if they're very highly myopic, we might refer them for a tube as a first line surgery because trabeculectomy is going to be higher risk. Surgery in general, if someone's telling you need surgery, the benefits are going to outweigh the risks. But it's just which type of surgery to do in a highly myopic patient. It depends how myopic you are, of course, but in general, I mean, I've referred patients for tube surgery to various places, and they've always said try trabeculectomy first. So it depends on the patient, but if someone's recommending surgery because your glaucoma is out of control, then probably the benefits outweigh the risks, if that's the question. I've recommended to massage my eyelids after using an eye warming eye mask. Is the problem for eye pressure? So presumably that's for blepharitis. You've been recommended that treatment. It's a good question because we don't like eye rubbing. We don't like too much pressure on the eye from fingers. Can cause a rise in pressure. So it's tricky. I would suggest if you've got glaucoma and they've been told to massage them, I would massage the lid by pinching the lid between your finger and thumb like that, massage across rather than putting pressure on your eye. So no pressure directly on your eye, but just the glands are in the lid. So if you can massage the glands without pressing on the eye, that would be safer for you than pressing down on the eye itself. I like this. This is rapid fire question. I like this. It's fun. I have pseudo-exfoliation syndrome glaucoma. Eye pressure fluctuates a lot, usually around mid-20s, but I have thin corneas. I'm 72. Would you recommend Presoflow or Trab? It is not yet advanced, but have been told I will need surgery in this eye ASAP, especially as it is a pseudo-exfoliation and thin cornea. Okay, so I think if you've been told that it's not advanced yet, your field defects are not advanced, then you could go for a Presoflow. I think if that's what you've been offered, that's fine. I think 72 in my day was getting on a bit. These days, 72-year-olds look much younger than me. So you've got many years ahead of you. You might want to consider a trab because that's going to be a much better lower of pressure and your pressure for longer. And of course, if you have a Presoflow, you won't be able to have a trab afterwards because it's going to cause all that scarring and things. So it's an interesting question. Without looking at your visual fields and knowing exactly how advanced you are, I wouldn't know what to say. But if your clinician is suggesting Presoflow, then I'm sure they have a good reason for going for that first. But either will lower your pressure and buy you many years of time, I would have thought. What is the best time to use drops that are prescribed for use at night? We get this question a lot in patient support groups. I mean, what is night? Every person has a different bedtime. So we tend to say, keep it the same time each night. Now, if you're a night owl and you go to sleep at 2 in the morning, probably better just to take it at 10 and then take it at 10 every night. There are some people who do night shifts. So what is nighttime to them? So I would say before you go to sleep. So pick a time before you actually go to sleep, and that's the time to use it. It's mainly because the nighttime drops work best at the peak pressure they normally get in the night from normal diurnal variation. So as long as you keep it the same, I don't think it matters too much. But nighttime ones mean close to bed time, but not early evening. So make of that what you will. But as long as it's the same time every night, I think you'll be fine. Can you do a trabeculectomy after an eye stent and cataract? Yes, that's one of the advantages of using the eye stent. The eye stent just goes inside the drainage angle when you're doing cataract surgery, doesn't affect the outside white of the eye, which you need to be clean to do a trab. So that's actually one of the benefits of doing that, because you still got the option of a trabeculectomy afterwards if the glaucoma is still not controlled. So the simple answer to that is yes. Is there any known link with squint operations as a child and glaucoma? I don't think there's a direct link with squint surgery as a child. Sometimes people that have had squint surgery have an unusually developed optic nerve and eye anyway. And that's why it squints, because it doesn't see so well or whatever. But I don't think there's a direct link as far as I know. As long as the squint operation hasn't caused too much scarring, you should still be able to do a trabeculectomy in the future. What is the, oh, we've done that one. Can you wear contact lenses occasionally if you have glaucoma? There's no reason why you can't wear contact lenses. The only issue is the drops. Are they drops that penetrate through a contact lens? So there are some drops that will be better to use in contact lens wearers, and also you probably want preservative-free drops so that you can still wear contact lenses. I wouldn't wear contact lenses too long. Generally, I say this to all contact lens wearers: don't wear them 28 hours a day, and not 8 days a week. You know, you need to let your eyes rest a bit in between. And I would suggest dailies are safer than monthly. Monthlies have a higher infection risk, so stick to dailies if you're going to wear them. But there's no reason why you can't, as long as you just check with your clinician of the drops you're on and make sure that they are suitable. You could put them in, the drops in before you put the contact lens, and put them in at the end of the day as well. Gosh, is that the time? I'm enjoying myself too much.
I know we've probably got time for a couple more, and then we can.
Okay.
Yeah,
I can keep going if everyone's. How many people? We've got 120 people online. So I'm a previous steroid responder, pressure of 58 after bleb needling with prednisolone, but have had no steroid response after Paul Tubot with same prednisolone. Okay, so the reason for that. So these are good questions. So for those of you who don't know, some people are prone to getting a rise in pressure because they use steroid drops or steroid creams or steroid tablets, any type of steroid. So when you've got a tube or some instrument that bypasses your drainage angle, you solve the problem, because the steroid causes the trabecular meshwork to not work. So if your normal intact drainage angle doesn't work very well, you can get a steroid response. Now, if you bypassed it with a tube and that's draining, then there's less effect. It doesn't really matter what the steroids are doing to your drainage angle, because the fluid is all flowing through the tube and not your drainage angle. I hope that makes sense. So that explains why the steroid issue is much less once you've had some sort of tube surgery.
So I was thinking, Areeb, would it be possible, maybe, should we say no more questions, but maybe we'll stay on for a bit longer to answer some
I'm
of the
happy.
questions. So
Yeah,
maybe if we can try and do that, and maybe kind of finish 10 minutes later if everybody's okay. And then
Yeah,
I'll
I'm
wrap up
happy.
with the thank yous, but we'll have a deal.
Yeah, I mean, I love these questions coming in. How often should a person be examined to establish, I lost the question now, to establish the rate of glaucoma progression? Again, that's person specific. I think if somebody is stable, in my department, we might do yearly. Occasionally we do 18 monthly, but might do yearly. And also we might do a yearly virtual, meaning you come in, you have all your tests, you go home, and we review it online, and we decide whether there's any progression, whether you should come in sooner or not. So that's the low end of the spectrum. If somebody's progressing, I have what we call a red clinic, where me and my colleague, we see the most worrying patients that we think are progressing, might need surgery, or we really need to get involved. We may be seeing them once every couple of weeks if we have to. Generally, it's 6 monthly if people are more stable with moderate to advanced glaucoma. Low end of the spectrum with ocular hypertension, maybe yearly. And also you might not see me, you might see my colleague, the optometrist or the glaucoma nurse, because you're low risk. So it all depends on where you're going, but that's the general. If you're being seen for less than 4 months in my clinic, I'm worried about you.
Right, we've got
Uh,
a couple of questions that come through from social media, so we'll just be able to
yes.
answer those. So it says, they're a side sleeper and worry that might be making pressures wrong. They do have an adjustable bed, so what would you suggest?
It's difficult. You've probably been a side sleeper all your life. It's very hard to change that habit, and your body tends to do what it wants. So you'll go to sleep on your back and wake up on your side, won't you? You just fall back to where you normally do. So sometimes you can't help it. But I would suggest, if you can, to lift your head up a little bit, buy a pillow or two, and get used to doing that, because that will help your blood flow. Um, the main risk is sleeping on your face. Some people sleep face down in a pillow. That's not good. But sleeping on your side, it is what it is. Some people change sides if they've had operation on that side. How they change habits, I don't know. A thick pillow, maybe to stop you rolling back over. But head up is the main issue. I think you may not be able to change the side, but head up.
Thank you. And one more actually. It's is it possible to for ocular hypertension in one eye not to lead with glaucoma, but have glaucoma in the other eye?
So you cut out a bit there. Say that bit again.
Sorry, it's is it possible to have ocular hypertension in one eye and glaucoma in the other, but the ocular hypertension in the eye not to lead to glaucoma? So one kind of like just hide.
Absolutely. Yeah, I've got people with rip roaring glaucoma in one eye and a perfectly normal eye in the other eye with no drops or anything. So nature doesn't follow any rules. So of course you can. Yeah, and generally, if you've got ocular hypertension, we're going to be treating both eyes anyway. So we probably have prevented that developing glaucoma before it started, because each eye might develop at a different rate. So yeah, absolutely, you may never have a problem in the other eye. I'm happy to say, or I'm happy to do this again, because I feel that lots of people have not had their questions answered, or I can do it online afterwards. I don't know how you want to do it.
Well, we can maybe try
Um,
and find a few of the most common ones we've got here. That's got seven. Is it inadvisable to use a heat pad for dry eye and blepharitis? So seven people have liked that one.
it's difficult because blepharitis is the bane of our lives, because obviously our drops are going to make it worse. And we need the drops to go in. So we would like the blepharitis treated. Um, I don't think there's too much of a problem using a heat mask and massage, as long as you're not pressing on the eye. I think it's only going to help get rid of the blepharitis, and therefore you're going to take your drops more, and then that's going to treat the glaucoma. So I think the benefits outweigh the risks, really. Um,
Um, this is a kind of one that we've had a couple of people here. It's in the Q&A. They've been on drops for 6 years. Latanoprost, timolol, and dozonamide, and they've gained weight, and then makes them unable to kind of then feel like exercising, and become unfit. Do they think is it the drops that have done this? Could it be the drops that are causing this kind of like situation?
um, Never say never, but that would be a very rare and unusual side effect, I would say, of drops. I don't know whether you've been told to do this, but when you put the drops into that lower lid there, you pop the drop in there and then you press really hard against the nose to block the tear duct, so that the drug doesn't go down the nose and into the back of the mouth and into your system. And that will help reduce any side effects in your body. I would be surprised if it's the drops. You may need to look at other things. I mean, I've had patients who've been on drops. They take the drops and they get double vision. They stop the drops, double vision goes away. Amazingly rare side effects. I've had people who are on drops, they've got hallucinations and they've got used to them. And they know if they stop the drops, the hallucination goes away, but they're worried about the glaucoma. So the drops can have weird and wonderful side effects, but weight gain, I mean, if you wanted to, with your clinician, you could experiment. You could stop one of them and see whether that helps, as long as they can cover the pressure with some other way. I do that sometimes if there's unusual side effects, but I'm not sure. I can't say for sure if it's the drops. That would be very rare.
Thank you. Trying to work out what else there is. It says, can you take your head down when you're gardening? So like weeding. So we're talking about obviously I know we talked earlier about kind of
Yeah,
downward dog and all that kind of stuff, but I'm guessing
yeah.
gardening and weeding. What do you suggest?
I mean, look, gardening's good for your health. It's very good for your mental health. Bending down is always going to be um, a bad thing, or something that we suggest you don't do. Whether you can weed by bending your knees down, or I don't know if you can sit on a stool and weed. I don't know whether that's possible. But the less bending down with your head below your heart in that position for a long time, the less you do that, the better. Or get a gardener. That's the other option. But I mean, generally, if you can sort of sit on a stool or something and do it rather than bend your head down, that would be better for you.
So we've got one that's got missed earlier. The risk of cataract and vitrectomy surgery is the first eye. The glaucoma progressed quickly.
Risks of cataract and vitrectomy surgery as first eye glaucoma. Oh, okay. So a lot of our business comes from our vitreoretinal colleagues. They do vitreoretinal surgery for retinal detachment or something, and for some reason the eye loses its power of controlling its eye pressure. Very common pathway leading to the glaucoma clinic, I'm afraid. I'm not sure it's fully understood exactly why, because some people don't, some people do. But glaucoma can start after vitreoretinal surgery, and it can progress faster after vitreoretinal surgery. I'm afraid that's just one of those things. And the vitreoretinal surgery was definitely needed, so we just have to manage the aftermath as and when. I love this question about field tests being horrible. Is there any device to measure visual field in process to improve accuracy in patient experience? The visual field test is horrible in capitals. Everybody hates field. No patient comes to me and says, "Oh, I love that field test. Can I do it again, please?" Everybody hates them. However, it's still the best test we have to look for progression. And one of the reasons it's horrible is because it's hard. There's no point in having an easy test. It has to be difficult to bring out the problems. If you have an easy test, everyone would pass it, wouldn't they? So there's no getting around it. There are some patients just cannot do it because they're all over they're over pressing, or they're not pressing, or they fall asleep. We have to give up on them. But in general, I'm afraid it's a necessary evil if we can get away with persuading you to do it. I might reduce the frequency in your case, but unfortunately, it's what we've got. I've been diagnosed with an optic disc pit as well as glaucoma. I've lost some fine vision and difficulties in maintaining eye pressure. Will high pressure force the pit to open again? How do we know it closed? I mean, optic disc pits are generally a congenital malformation of the optic nerve. There's a little pit there. So generally they don't close, they're just there. So I'm not sure it's closed, and I'm not sure the relationship with the glaucoma. I mean, I think they're two separate issues. The only connection is that the optic disc pit can sometimes confuse the clinician when they're looking for glaucoma. It can either look like glaucoma and not be, or it could be glaucoma on top of the optic disc pit appearance. So it makes the diagnosis a little bit tricky. But I don't think there's a closure of the pit. I don't think it ever closes. It'll just always be there. Does a highly tilted optic disc affect glaucoma? Is my neurofibromatosis type 1 linked? Wow. That's a bit complex for me to answer in this format. Tilted optic discs are just a malformation, or not malformation, a different formation of the optic nerve that you were born with. Doesn't usually have any consequences, not going to change, but they can have a field defect associated with it. Neurofibromatosis is another issue that can cause glaucoma. It's probably a bit too complex for this forum. What would you avoid? When would you avoid drops containing beta blockers with a low heart rate? Okay, so beta blockers, great for lowering eye pressure, but come with a lot of side effects, one of which is low heart rate. If you already have a low heart rate, I would.
Hi, I think we've lost Areeb at the moment. So what I'm going to do is hopefully he'll kind of come back on again, and I'm going to show the last slide. Hopefully and then if he comes back on, we can answer the remaining questions. So just bear with. There we go. So he's coming back. So hopefully he hasn't deserted us.
I got kicked off.
I know.
Have
I
you had
was about
enough of me? Is that
No,
what
it wasn't. Yeah, I actually pressed the button. No, it wasn't me. It
Okay.
really wasn't me. So yeah, so we've got, if you wanted to ask a few more questions and then we can
Uh,
wrap up.
I'm
Um,
I'm more than happy because I don't like disappointing people who've been waiting for ages to have their questions answered. Just going back to Q&A. Where's the Q&A? It's under more, isn't it? Yeah, more.
it was,
Um,
which one was it? Was it the beta blockers? Was that one?
I can't see the Q&A anymore, so you'll have to ask me the questions.
Right. So I can't remember which one you answered, but when would you avoid drops containing beta blockers with a
Oh
low
yeah, that's
heart
right.
rate?
So the contraindications are low heart rate, asthma. It can make asthma worse if you've got known asthma or COPD or any breathing problems or chest problems. Or if you're excessively older, I wouldn't give it to like a 90-year-old. I would try and avoid beta blockers because their effects are much more pronounced in older patients. So those are the main people I would avoid beta blockers for. I
Thank
had one
you.
patient who was being investigated for impotence by the urologist for ages, and yeah, it was on a beta blocker. So I stopped his beta blocker, and lo and behold, it cured it. So weird and wonderful side effects from drops, but yeah.
I think, yeah, they do all affect each other, don't they? So this one, can you do a trab after an eye stent and cataract op?
Yeah, I've done that one. Yeah, definitely. That's the advantage of using the stent that you still got the
Perf
option to do the trap.
Perfect. So it's got here, so, and apologies if I don't pronounce it right. Is it melanoma affect glaucoma?
Melanoma. Does it say melanoma?
I think it might be melanoma. I don't know.
Meningioma.
There we go. So it's me
Meningioma.
pronouncing.
So
There we go.
that's a brain tumor or brain growth. Um, can it affect glaucoma? It can affect your visual field and confuse the issue, but we are aware of different shapes of visual field when it's a brain related problem or when it's glaucoma. They look different shapes and patterns. So we can usually tell this patient needs an MRI scan. So it can confuse the issue. Whether it causes I don't think it can cause glaucoma as such, unless it's pressing on the eyeball itself. But meningiomas tend to be further back in the brain, and that's really the main connection. So you can have both things, meningioma and glaucoma, but I'm not sure of the connection between the two.
Thank you. We've got here, I believe that dry eye drops containing petroleum jelly may cause problems with the pressure flow. Are there any other eye drops, I'm guessing dry eye drops, that can cause problems with these also?
So it's an interesting question because the flow is under the white of the eye. It's buried under the white of the eye, and the tube goes into the inside of the eye. So anything on the surface doesn't really affect it, except if it's scarring. If it's beginning to scar, you want to you want preservative-free drops so that the scarring is limited and it can keep flowing. So yes, you want something that's preservative-free for your dry eyes. Petroleum jelly, I'm not sure in itself. There are better options probably. You have to talk to your clinician, but mainly it needs to be preservative free. But the PreserFlow action itself is, if it's working really well, it should be fine. But I would avoid preserved drops.
Thank you. Um, are there any special precautions that they should know about before having a general anaesthetic for a parathyroid condition?
What, related to glaucoma?
I'm guessing, if they're having a general with if might increase the eye pressures. I'm not sure. I mean, what about general, generally a general,
Generally, in
yeah.
general, general anesthetic is, well, the effect of general anesthetic is probably to lower pressure in the eye during the surgery. Um, So no, I don't think there's any particular precautions you need to take. Um, I have had people develop glaucoma or get glaucoma worse with very long procedures, especially when they're lying on their front. So spinal surgery, things like that, for 5, 6 hours. They wake up and they've got, either poor vision or lost vision, or so if it's a prolonged operation in an awkward position with a face down, definitely need to be discussed with the clinicians beforehand. But if it's a routine general anesthetic, which is not face down on your back, generally it's safe. I mean, you got the operation's been done for a reason, so you can't really say no usually. Um, but no, I think that will be fine.
Right, so we've got here. So how long after a trab is it safe to have the cataract surgery?
That's a good question. So generally, I try and do the cataract first, get it out of the way. If we've got time, if the glaucoma progression is not too bad, and we can plan to do the glaucoma surgery, trabeculectomy in say 6 months or so, I would try and do the cataract now because A, that lowers pressure anyway, but B, it gets the cataract out of the way. So doing a cataract after trabeculectomy is much more technically demanding. And if we did the cataract after trabeculectomy, there is a risk that the trabeculectomy fails because of the inflammation you get from cataract surgery. So in general, I would always try and do the cataract first. But if we haven't got time, if it's very progressed and there's a danger of losing vision in that time, I'll do the trabeculectomy first and we'll deal with the cataract later. But I wouldn't do the cataract for at least 3 to 4 months after trabeculectomy surgery. They used to do them at the same time, cataract and trabeculectomy. They found it wasn't working, it didn't work so well because the inflammation caused the trabeculectomy to fail, scar up. So we tend to do them apart. Depends on your glaucoma whether I do the cataract first or do it a few months after the trabeculectomy.
Thank you. I'm not sure this one's specific, but it says, is laser surgery safe? Safe. Is laser surgery safe and effective to bring down IOP before surgery to remove a silicone oil in place for 3 years after a detached retina, twice in the same eye?
Wow, that's a pretty specific situation. Laser surgery, though, what laser are they talking about there? I'm not sure which, depends which laser you're talking about. There is a laser surgery too for an eye that has poor visual potential, and we've tried everything, and it's full of oil and so on. And that's called a cyclodiode laser that you do from the outside. It's really to destroy the tissue inside the eye that produces fluid. So you're turning the tap off, and it's really a destructive laser. So we're doing that because we've got no other options, and the eye has a low chance of regaining useful vision. But I'm not sure what other type of laser I would use in an oil-filled eye, unless it's a retinal laser they're talking about. But I'm not
Maybe it's
sure
not
about the
quite
answer to that.
glaucoma specific.
Yeah,
Yeah.
yeah.
And obviously, maybe kind of what's the difference between SLT and trabeculectomy? Just I suppose in a just a small kind of
SLT
nutshell.
is a laser treatment you do in the clinic setting on a slit lamp. You sit on a slit lamp and you fire a laser into the drainage angles of the eye, which is it's a painless laser. And it takes 10 minutes to do maybe, and you go home the same day. Trabeculectomy is a full-blown operation, takes an hour at least, and you need to be put to sleep to do it in theatre. So it's a much bigger procedure, and for more advanced glaucoma.
So, what's your thoughts on the mini jet? And I'm guessing that's a mix. Whether
I
it's obviously
think
it's a
it's a MIG,
specific.
isn't it? I'm not that au fait with Minijet. I've never used it, so I can't really answer that question. But if it's another MIGs, I mean, um, they all have their success rates, some of which come from the company. So you take it with a slight pinch of salt. But you'll have to talk to your clinician about that. I haven't got much experience with Minijet, I'm afraid.
Thank you.
Uh,
Two more questions, and you'll like the last one. I'm going to save it for the last one.
okay,
So,
okay.
if Preserve fails for someone with pseudoexfoliation glaucoma, what would be the next intervention? And the same question, obviously, if a trab fails. So, what would you do if they have that particular type of glaucoma?
So
If those fail?
I think if Presiflow has failed, I don't think they'll be able to do a trabeculectomy unless the pressure flows over to one side and there's enough space to do a trabeculectomy. Probably they would go for a tube after that, refer you somewhere for a tube surgery. If and the other one was if trabeculectomy failed.
Yeah.
Well, if trabeculectomy fails, you can't redo it because you've had surgery for it and it's not going to work second time around. So you would probably go for a tube. I think you could still do a Presiflow, be tricky, but if you've already gone for a trabeculectomy, presumably it's advanced glaucoma, so you'd probably refer for a tube. Tube is the ultimate operation, I think. After that, you can put two tubes in. I've seen patients with two tubes, so that would be the last straw, really.
So the very last question isn't a question. It says they're very lucky to have you as their doctor, and it
Ah,
actually has two
oh,
likes on there as well. So
ah,
that's. I just thought I'd save that to the end because that's actually,
oh,
um,
that's nice to hear, isn't it?
yeah,
That's my
yeah.
that's my mum. That is. No, it's not. It's not. That is a patient. I recognize the name. Thank you for that. Appreciate that. That's
Yeah.
very nice of
So
you.
I'm just now going to share my slides for the last, but thank you very much for kind of like,
You're welcome.
I say soldiering on, but actually it was a pleasure.
It is a
Um,
pleasure. I love it. It's
yeah.
great.
So let me
Um,
just,
I'm assuming everyone enjoyed it. If they didn't, that's fine. If they did, I'm happy
well,
to do it again.
they're still here. They haven't, we're not on our own. We have actually got, we've still got as many people, I think,
90
as
odd people.
started.
Wow.
So that's pretty good. So,
Good.
absolutely, that is amazing, and thank you for being absolutely a superstar and answering all those questions, whatever was thrown at you. So that's absolutely fantastic. So we're going to share the final poll and hopefully show that I have definitely learned something tonight. Um, so please contact the helpline. As I was going to say, please contact the helpline for any questions we didn't get through, but we actually have got through them all. But there's a few from social media, but most of them we've got through. So if you want to make note of the helpline details. It's you can call them on 01233 648170, or you can email them at helpline@glaucoma.uk. So the next two webinars, if you're interested, I know you are Living Fully with Visual Impairment on the 10th of March and a research update on the 22nd of April. So I'm just going to just say thank you to Areeb, and just to remember that your circumstances are unique to you. So if you're thinking about making any changes as a result of this webinar, please do speak to your eye specialist first. So we are, Glaucoma UK and Areeb are not responsible for any actions that you may take as a result, get my teeth in, as a result of the information you learn through this webinar. If you have any other questions that you would like to ask related to glaucoma, please give our helpline a call or drop them an email. So thank you for joining us on this webinar. We really value your feedback. So if we would be very grateful if you could complete the evaluation form, and that will be sent in a link tomorrow. So thank you very much for everybody. So I'm going to end the webinar. I think we've had the questions. So I'm going to end the webinar, let everybody go back to their evenings, and thank Areeb, and thank you all.
Thank you. Thanks for everyone.
Bye bye.